In terms of treating patients, we obviously see people in our office that either make an appointment or are referred in, but a lot of times we'll get a phone call from a friend, or someone might stop us at church or in the grocery store and say, hey, my knee's been bugging me, what do I do? So we just try and listen to what the patient has to say. The patient usually can make the diagnosis for you if you just let them tell you what their particular ailment is causing, pain, swelling, instability, catching, locking. So I'm always, really attentive to what the patient has to say. And then, there's some redirection in certain areas to answer specific questions that might have been overlooked by the patient, so that we're not overlooking anything. And then examining the patient and seeing if you can already put two and two together with what they're telling you. See if there's a certain ligament that's been damaged, or a meniscus that's torn, that's catching in their knee and locking up in their knee. And then as needed, discuss the investigative studies that need to be done to confirm your suspicions. Or if you don't know what's going on, still listen to the patient. You maybe put them through a course of physical therapy, brief use of anti-inflammatory medications if it's a bursitis, for example, or a tendonitis. But if things don't improve, then don't ignore the symptoms and tell them nothing's wrong. Just continue with your investigation as to getting x-rays and MRI if needed. Technetium bone scan is something we use sometimes too when people have stress in bones that would be missed on an x-ray or an MRI. And then visit with them in terms of the findings and discuss the multiple options there are. So if we haven't done any studies or anything, but I feel quite confident about the diagnosis, and I feel that a course of conservative treatment and time will take care of it, showing the patient the necessary exercises to do, and giving them the option to see a physical therapist, but having them start on something even before they see the therapist. So I frequently have sheets with instructions on how to do certain exercises. And, if it's a medication course, I'll usually give them a 5-day course of anti-inflammatories like ibuprofen, and say just take 2 or 3 pills 3 times a day for 5 days, and if things feel great, taper off of it over the next 10 days. If it hadn't done anything, there's no point in continuing with that medication. You can just stop it, or if it's bothering you, just stop it right away, bothering your stomach. So then if I believe that a condition is unlikely to be resolved with pills or with conservative measurements, I'll get them involved with a physical therapist or an interventional radiologist if they need certain injections in different parts of their body that are a little more complicated. Or if I can do the injection, I would do it in the office. And then if it was something that was clearly not manageable with conservative treatment, I would give them the alternatives for a surgical option, and then I would show them diagrams in our book, or use a knee model to show them the different parts of the knee that could be affected, whether it's the underside of the patella, which frequently gives people problems with noise and crunching in the kneecap area, or some problem with the meniscal cartilage right here might be torn, or the anterior cruciate ligament right here that could be torn. And I'll show them how the knee can be unstable when these ligaments are not quite right. And I can also show that to them on their physical exam, and they'll frequently say, well, that's it, that's what my knee does. You just did what my knee does when I'm jumping on it or landing on it funny. So we tell them about the surgery and how long the surgery takes, what the risks and complications are, how long we expect rehab to be, what we expect the patient to do to protect the operation, and how often they would need to see a therapist to make sure that their knee gets strong again or their leg gets strong again without overdoing it or not doing enough, and the time period in which I would expect recovery to occur. Although I said earlier that we are lucky because the body heals many things, in orthopedics, one dilemma we have is that we can't figure out how a fracture heals or how cartilage heals itself. Fractures sometimes don't heal as fast as we'd like, but eventually they do. Most fractures will heal at some point. And cartilage, we have some more innovative techniques to try and get cartilage to regenerate again. The length of rehabilitation really is very injury specific, and it's also very patient dependent. Patient in two ways: the patient himself or herself needing to be patient and let things heal in time.